Hello and welcome to the July edition of Ask Your Doctor. I'm Dr. Alan Thornhill. I've been working in the field of IVF for over 25 years in a variety of different roles, starting as a clinical embryologist in the lab and now providing support and guidance for patients as a fertility coach. This evening, I'll be your host for what's going to be a really interesting and important session. There are so many things that are within your control and many things that are outside of your control that can have an impact on whether IVF works for you or not. Some of them are really fundamental and apply to everyone, but many are very specific to your particular circumstances. However, tonight's topic, I think, is probably one of the most frequent questions asked by IVF patients. And that is the title of tonight's session: what are my options if I have low ovarian reserve? I'm joined tonight by a fantastic set of panelists who are here to help you better understand this. They are Dr. Nicole Mardešićová, Head Doctor of PRONATAL Group in Czech Republic.
Right.
Thank you. Thanks for being here. Dr. Elena Puente, Medical Director of Clinica Fertia in Spain.
Hello.
And Dr. Evangelos Sakkas, a Medical Director of Gyn Care IVF in Greece. Now, what I'm going to do, we've got a few questions already in, but I'm going to start by asking each of our panelists to answer one of the fundamental questions so that we're all on the same page, because we've had a few sessions in the past where we've half an hour in and someone says, what's AMH again? And, that's our mistake. We should be, getting you on the same page from the beginning. So that will give us a brief introduction to tonight's topic, and then we'll answer specific questions. I'm hoping that we'll cover what you as a patient can do to give yourself the best chances, what the clinic can do, and the relative importance of each. So that's something we'll try and come back to. Please feel free. There is no silly question. Please put it in the Q&A box, ideally, because otherwise I have to kind of look between the two different chats. So if you can put your questions in the Q&A rather than the chat, that'd be really helpful. And then we'll try and answer all the questions, but I will prioritize the ones that are based on tonight's topic and then the other ones later on. And if it's super long and super specific to you, maybe that's something we can take offline with one of the doctors, me, or you can email us later. Okay, so let's kick off really with the first question that we've got, one of those fundamental questions. What do we mean by ovarian reserve? So I'm going to ask Dr. Nicole to answer that one, please.
Hi, everybody. Good evening. So I will try to answer the question so everybody can understand in a really easy way. So the ovarian reserve is basically the marker, the number, how many oocytes, how many eggs you have left, or how many eggs you have. We women, we are born with a certain amount of oocytes. And this is our ovarian reserve at the beginning when we are born. And then as we age, the ovarian reserve, of course, diminishes. And it is very individual how quickly the ovarian reserve diminishes. So this is very individual. It can be very hardly predicted. And the older we get, the lower ovarian reserve we have. So ovarian reserve is the number of oocytes you have left in your ovaries. And of course, the lower your ovarian reserve gets, the harder it can be for you to get pregnant. That is dependent on age as well. We will surely talk about it later on.
Perfect. That was a beautiful answer. Thank you very much. That was great. That was really comprehensive, covered everything in a really understandable way. So let's all try and keep our answers like that. So Dr. Elena, can you answer this one, please? When does it start to deplete noticeably, that reserve? When should we start worrying about it?
Okay, well, as Dr. Nicola has mentioned, we are born with a certain amount of eggs. This varies among different ladies. Obviously, we know that if our mothers enter menopause very early, then most probably our ovarian reserve will be lower than a lady who's born from a mother who gets her menopause on her 50s. But in general speaking, we know that as is mentioned, ovarian reserve is declining with age. When we get to our 30s, this decline is starting and then it starts to go very fast once we reach 35. In fact, the ovary is one of the organs that is getting older in a faster way. We lose 80% of the ovarian function in just 5 years. From 35 to 40 years of age, we are losing 80% of our ovarian reserve, which is dramatically. That's why age is such an important factor. This is the one that worries us more, besides obviously ovarian reserve, age is the most important prognostic factor in terms of ART treatment.
Perfect. Thank you very much. That was lovely. That was comprehensive, and I'm sure, I'm hoping if any of the people watching want to ask specific questions related to what you're hearing, that'll be great, because I think there's nuances all around. So that leaves us with the final kind of icebreaker kind of question, and that's to Dr. Evangelos, and that's, how do we measure ovarian reserve?
So thank you, Alan, for this nice question. Actually, the only tool we have, the most recent one, is the AMH, which is a simple blood test that we do at whatever day of the menstrual cycle of our patient. Before the AMH, we used to do the combination of FSH, LH, and estradiol, which are 3 hormones that we used to do in the beginning of the cycle. Now we use the AMH that, as you know, we can do it in every lab, and it gives us a result. So what's very important to underline in this case is that AMH reflects the ovarian reserve, but it doesn't reflect the ovarian quality. It reflects the ovarian quantity. It's not a marker of the quality. And that's something that our patients should bear in mind, because it's very important, because very, very often they get stressed about that. Of course, you have to pay attention before interpreting the result, because if you see in a woman of 30 years old, let's say 2 nanogram per milliliter, it's quite a good result. If you see the same result in a woman of 20 years old, maybe it's not so good. Then you must also pay attention to the reference. So one thing is measuring it in nanogram per milliliter. Another thing is going in picomole on liter. So attention when interpreting the result.
Okay, thank you very much. Just a little follow-on question for you for that is, you talked about the historical hormone measurements, which I guess are not done for the same reason. They're done, but they're not done with the aim of looking at the reserve. Have you got anything to say about antral follicle count as a, adjunct, or is it better, worse?
Of course. The workout you have to do with the patient when she comes to your clinic is always the AFC, so the antral follicle count, done by ultrasound, a vaginal, transvaginal ultrasound, AMH, and we usually always add FSH and estradiol. But let's say that today we most depend on AFC, antral follicle count, and AMH. Of course, many years ago we also did the inhibin, but let's say that it's not done anymore.
Okay, thank you. Great. Well, I hope that's given a nice sort of introduction to the topic. But if this is really important, if anyone's watching and you go, oh, there was an acronym, some letters used, didn't know what they were, just pop it in the Q&A and we'll address that immediately. Okay, because we don't want you sitting through 30 minutes of stuff you don't really know what we're talking about. Okay, so let's go to the first question that's been sent in. So we're going to go to Dr. Elena for this one. Okay, we're going to, not go in the same order all the time. So this one is, my AMH is 1.05. We do need the units there, I guess. And I'm 35. My mum had me at 35 and my brother at 36, and then went through early menopause at 37. I had a chemical miscarriage at 5 weeks just last month. Is donor egg IVF a better option for me? Is the miscarriage a reflection of egg quality? So I guess that's 2 questions there. I was advised against own egg IVF as there's not much to stimulate as is. So there's quite a lot to pick apart there, but maybe start with the using own eggs.
I think it's very important, the first part. She's 35 years of age, and this is the most crucial point. When you are 35, the quality of your eggs is good. The one thing, as Dr. Sakkas has mentioned, is the amount of eggs, and another different thing is the quality. When we are speaking about AMH, we are speaking about ovarian reserve, about quantity, is the number of eggs you have left, but it doesn't mean that the quality is not good. So this AMH, okay, is a little bit lower than it should be for her age, but her age is very good, so we can expect very good quality of eggs. She's got a miscarriage, and we cannot say that because she's got a miscarriage, her eggs are not good quality. 5% of ladies have a miscarriage being young, so that's something that could happen just by chance, and there's no relation with her situation. So I don't think it's a good advice to go into the explanation, because on one hand, her AMH, we could get at least 7, 8 eggs. And we know that if you are 35 or less, and you can get at least in between 4 to 7 eggs, you can get at least 1 euploid blastocyst. Euploid means an embryo that is genetically normal. And the probability for implantation in this embryo with no genetic abnormalities is 65%, the chance to have a live birth rate. So I think she can do with her own eggs. I don't see the point to go into the explanation, because first of all, age is the most important prognosis factor, and this factor is good for her. A different thing is when you are 42, 43, that's a different story, because you have lots of abnormal eggs. You will need over 42, at least 20 to 25 eggs to get an embryo that is genetically normal. And you cannot do that if your AMH is very low. But if you have 35 years of age, an AMH that is 1.05, I'm sure that she can get a good embryo and a pregnancy that can go to term.
Thank you. Really good, comprehensive answer. Normally I don't ask all the other doctors to answer the same question. I'm not going to. I'm just going to ask the very simple question. Would you give different advice? Start with Nicole. Would you give different advice in terms of whether they should have donor eggs at this stage or not?
For sure.
So if we really agree that her AMH is 1.05 nanograms, hopefully, because that would be a huge difference if this number was in picomoles. So if it is really 1.05 nanograms, then I certainly agree that she should go for IVF. With her own oocytes.
Thank you. And the lady who posed that question, if you could just pop in the chat if you know nanograms or picomoles, because that obviously makes a big difference. And that's why we stressed at the beginning that that information is really critical. Dr. Evangelos, would you do anything different from what you've just heard?
I totally agree with my colleagues. Only thing I would like to add is that given that her mother got in menopause very early, the only advice I would like to add is to not lose so much time. So better begin now with IVF, because before finding yourself at 40 years old with early menopause. And in that case, maybe I would add a genetic counseling just to add a karyotype and all the other exams that we ask in those cases. But I totally agree.
Perfect. Thank you very much, everybody. So we're sticking with you, Dr. Evangelos, and this is interesting. I read a recent article from The Guardian, so that's a kind of quite a highbrow newspaper in the UK, not a trashy paper at all, stating that AMH isn't necessarily a reliable indicator of ovarian reserve and anticipated success with IVF. I realize this question is kind of out of the context of the article, so you haven't got the article to read, but and it says thoughts ? So I guess it's saying what are the limitations maybe of using AMH?
I love this question. Thank you. Yeah, it's not 100% reliable. I mean, when a patient comes in our office, in our clinic, I think it's a huge mistake saying that we're going to construct a protocol of IVF stimulation based only on AMH. I know, of course, that there are many universities or schools or clinics that tend to do that, but I'm convinced that you cannot base yourself only on the AMH. So yeah, it's not 100% reliable, but it's the only biochemical marker that we have today. So if tomorrow I have to construct my protocol, my IVF stimulation of the patient, yeah, I'm going to take it into consideration, but I'm going to take into consideration the AFC, as you mentioned before, and of course the IVF history of my patient, because if she comes with the first IVF, yeah, but if she comes after 2-3 attempts, I also have more information in my mind for how to construct my IVF protocol. So yeah, it's very reliable. It's not the most reliable thing we have today, but it's the only thing we have, so we should use it.
Beautiful. So it's sort of use it in the context of all the information you have is probably a way of summarizing. Fantastic. Okay, Dr. Nicole. So sorry, I think I'll skip down there. Having an AMH of only 0.26 nanograms per mil left at the age of 41, would an IVF with, this is, sort of the other side of the coin from the previous question, would IVF with own eggs be still advisable, or should we think about donor eggs?
So that's a complicated question because there are more answers that we should get from this patient. Now, if I answer the question from the medical point of view only, which is usually impossible, but only from the medical point of view, that unfortunately this woman, she was 42, you said? That
41,
means that 41, yeah. That means that the quality of the oocyte, unfortunately, will be already quite bad because the quality of the oocyte is given mainly by the age of the patient. And we know that in this age, almost 80% of the embryos, of the end products of our stimulations, of our care, 80% are genetically unhealthy, so-called aneuploid. So now, given the information that this patient has a very low AMH, combined with her age, the chances for success with her own oocytes are very low. But now get to the center of our care, and that is the patient, that is the woman. Considering that she has never tried before, then as a woman, I completely understand that she would like to try the IVF cycle first to see, because there are many information that we don't have. What is her sensitivity of her FSH receptor to the stimulation? Maybe she will react a little better. Maybe we can use a soft stimulation, mild stimulation, not to lower the price, basically. So there are many options that we can use for her stimulation. And if she never tried before, then even though that we know that her chances for success are low because of low AMH and the age, I understand she would like to try. So there are two ways how to answer the question. From the medical point of view only, it's better to use the donor oocyte. But if she has never tried before, then definitely we can try IVF stimulation with PGT ideally. PGT is genetical testing of the embryos before implantation into the uterus.
That's great. Thank you for showing us the different dimensions of the question. It's not just about medical. I will pose this now, even though I don't think it's necessarily relevant for this particular patient's question because of her age. Because often we get people asking questions who are 43, 44 and above. And I often allow that sort of medical discussion, that kind of psychological discussion. And then I say there's also a kind of statistical honesty discussion, which is, have you, doctor, at your clinic ever had success with someone of this age? This isn't applicable to the 41, I don't think, but sometimes when it's 44, 45, and I think that kind of cuts through a lot of the other stuff as well, because if you're banking on this particular clinic with this particular doctor that you really like, and then you say, has it ever worked before? And the answer is no. I think that's another dimension as well. It would be for me, that's a dimension I think has to be taken into consideration. Okay, great. Thank you for that. Okay, I've got a question, but I'll ask it later. And I think it might link to another question that I've seen already. So, Dr. Evangelos, I'm an avid runner and average around 2,000 miles per year. That's already making me feel tired. Could this be a contributing factor to my low AMH? It'd be, oh yeah, we have got a figure there. I had it tested last year when I was 35. So lady is 36 now, and it was 0.9 nanograms per mil. So
the question is if extreme sport or sport in general can have any effect on ovarian reserve.
Maybe, and I think maybe add another dimension in as well that's not written but is probably true. Maybe the lady has a very low BMI as well. I would just maybe throw that in.
So of course exercise, it's only beneficial. There's no connection between exercise or even extreme exercise and ovarian reserve. Exercise means vascularization, it means blood flow, it means all the health benefits on the patient and of course on the ovarian reserve. Of course, just not to be how do you say, not well interpreted, it doesn't mean that we can improve the ovarian reserve. So you have ovarian reserve. If from tomorrow I go jogging or running or whatever you want, that will not improve, but it will not deteriorate neither my ovarian reserve. Of course, extreme conditions, as you said, I mean, extremely low BMI, yes, it could have an impact on the ovarian reserve, but all the other conditions, no.
Okay, so in summary, not really affecting AMH, but potentially other parts of the reproductive system, you know, having not the extreme exercise necessary, but the low BMI, because that is something that ladies often worry about, you know, the two extremes of BMI. Correct?
Yeah. So you have it's very often that we hear patients that have do extreme exercise for the Olympics, for example, as we have now the Olympics, and they don't have their period. That's an example. But not having the period doesn't mean that you don't have a good ovarian reserve. It doesn't mean that you're harming the ovarian reserve. It's another mechanism, a little bit more complicated, that interrupts your cycle. But the ovarian reserve is the ovarian reserve.
Perfect. Yeah, no, I was aware of that. I just wanted to, you know, I wouldn't want to answer a question and then go, oh yeah, there's loads of other things to worry about, but I didn't tell you them. So I just wanted to kind of pull that in if we could. Thank you. Okay, so, right, we're going to, what's the next one? Right, back to Dr. Nicole now. I'm 32 and my AMH is 0.74. My doctor told me that I should try to get pregnant naturally, not with IVF. What's the first step?
Sorry, did you ask me?
Yeah, sorry, it's you. Yeah, it's a difficult question because there's not much there. Yeah.
Yeah, well, there is one thing that we should ask this patient, and that is, how many kids do you wish to have? Because if this patient wants to have just one child, maybe she still has a little bit of time to try to conceive naturally. If she tells me I would like to have 2, ideally 3 children, then with this ovarian reserve, which is diminished, AMH 0.74 at the age of 32 is lower than it should be, definitely. Then if she wants more than one child, then some kind of fertility preservation is advisable. So in that case, I really wouldn't postponing the first pregnancy for longer. And to ask about the question, what's the first step? Well, sexual intercourse is the first step to conceive.
Thank you. Yeah, I really like, sorry, I'm scrolling. That's why it was difficult to do. I'm not a very good multitasker, I have to say. No, lovely. I really like the dimension you brought in there about family size, you know, not just getting one child, but having a family of a size you actually want. So that's great. Thank you very much for that. Okay, actually, I've got a bit of information in from the lady who asked the question originally. The AMH of 1.05 was picomoles.
Picomoles.
Oh, picomoles. Oh. Yeah.
So
well, then it changes the whole situation.
That's a different story.
Okay, yeah. But I think, Dr. Elena, I think that was your, I think it was you who answered that one.
Yeah, that was my question, and I thought it was nanograms per ml.
No, that's fine. That's good. Now we have 2. I think it's instructive to say if it was. This makes the point about nanograms versus picomoles really, you know, real, right? So if it was nanograms, okay, we have one conversation. If it's picomoles, as it is now, what do we say?
Yeah, but that's a different scenario for sure. But as Dr. Sakkas mentioned, we cannot base our treatment or the way we evaluate the patient just in the level of AMH. We need to know more things about this patient. It would be very important to check her antral follicular count. Maybe she's been on contraception for a very long time. This can affect the level of AMH. And for sure, I think she should try with brown eggs. Maybe we should tailor an appropriate treatment for this lady. Maybe we should think about different protocols, double stimulation, or it's very important for her. We need to tailor. When you have a very low ovarian reserve, the most important thing is what can you do for the patient, because every egg matters, especially at this age. because we know if we can get maybe 1 or 2 eggs from one cycle, we will improve her probabilities to have a live birth rate. So the main thing is to establish which is the best protocol for her. Should we use some kind of therapy to synchronize her follicles? Should we do a mild stimulation, higher doses, analog, some kind of add-on like Q10 or other antioxidants? I mean, there are many things that can be done. Obviously, we should have more information because, we don't know. It looks that it's something inherited, and she's low ovarian reserve because her mother is already got a ovarian reserve. First of all, we need to check the genetics, have the karyotype, X is fragile, before we try to start thinking about the stimulation. That's the basics. Have a good diagnosis, and then, of course, try to perform the best therapy for her particular case. And also, very important, never forget, we don't only need a good embryo, we also need a good uterus where the embryo can implant. And we should check as well for that. But I definitely think even her ovarian reserve is very low. At that age, she should try with her eggs, because as we've all mentioned before, the main prognostic factor is age. If you are 41 and your AMH is really very low, then prognosis is very good. But it's totally different when you are younger.
Perfect, thank you. I'm really glad that we had to clarify that, because it really does give a different answer, which is really important. Dr. Evangelos.
Just one, I totally agree. I would just advise the patient if she could repeat the AMH measurement, because it's really extremely, let's say, low, 1 picomole. So just to be sure, maybe in another lab, it wouldn't be a bad idea to repeat it, just to be sure.
Okay, perfect. Which is a really nice segue for you to answer the next question, because it talks to that point about repeating tests and different labs and things like that. So this person asks, my AMH dropped from 1.38 nanograms in March 24 to 1.05 in July 24. So that's only a few months. Is it normal for it to drop so quickly, or could it be a lab error? Well, before we say the word error, I would also say, was it done in the same lab? So there's quite a lot of dimensions to it. I'm only 36, so obviously this patient's now worrying that they've got a low ovarian reserve diagnosis or indication. So what would you say about that? About, you sort of hinted at it already, if you get maybe an unusual result. So can you talk us through your experience with lab results of this type, please?
Actually, I wouldn't be so stressed for this small reduction. I mean, 1.23 to 1.07. It's not something that really stresses me. Okay, at 36 years old, it can be many things. Okay, from lab to lab, from really many factors. Even the medical technology that we use in the labs may change from lab to lab. So this reduction doesn't really stress me. And at that age, I would really be calm. As we said before, it's not only the AMH. So I would just keep in mind that I'm 36 and I have an average, let's say a mean value of 1.2, 1.1. So it's more or less 1 point something, which means if I do an IVF, a production of about 8-9 eggs. So if I don't do an IVF, also good chances of being pregnant naturally. So it wouldn't be something that would stress me more than that. I would just take in consideration the other factors, and I would decide based on the whole image of the couple.
Okay. Yeah, I'd like to hear from the other doctors whether you agree with that, or what would stimulate you to say to someone, I think we're going to repeat that? Because Nicole, please.
Yeah, well, I wanted to add one more thing. I see it quite often, and probably my colleagues as well, that people get really fixed on numbers. We are not machines. We are humans. We are biological living things. Yeah. That means no number is ever the same. Spermiogram is never the same. FSH is never the same. Even if we measure it at the same time in the next cycle, you see, we are living human beings. So don't get fixed too much on little differences. Like for me, 1.3 and 1.1, basically for me, it's the same. Yeah, because as I'm saying, and as Dr. Evangelos says as well, AMH is fluctuating as well. I mean, if you look in the data, if you look in the studies, what you read is that AMH is stable. It doesn't fluctuate intracyclically, intercyclically. All of us that test AMH regularly on a daily basis, we know that it really does. I mean, you can test a patient 5 days later, and it is not the same number again. And I think the reason behind is the biology. Yeah, so of course it is good to test in a different lab, or you can test a little bit later, a couple months ago, or 3 weeks later. But still, we are only living humans. Yeah, so don't get too fixed on little things in the numbers.
Oh, thanks. That's really good advice. You know, especially someone who's I didn't do that particular test, but someone who's run a lab in the past. You know, I like to say to people, no test is perfect. You know, nothing's 100%. It's just to get you into that groove that yes, it's reliable, yes, it's accurate, yes, it's been validated, but there are some variations. So that's really good advice. Thank you. So sticking with you, Dr. Nicole, are there any supplements to improve egg quality? So we're talking about quality now, not reserve.
Yeah, so this is quite a very controversial theme. So maybe my colleagues will not agree with me. We will see. I think we have nothing to offer. If we look in the data, we tried almost everything that could possibly work to make the oocyte quality better. DHEA, antioxidants, estrogens before the cycles, whatever. Then if you look in the RCTs and in the data, it does not work. Unfortunately, I think we have nothing to offer. There is no rejuvenation, although you can read about rejuvenation being studied, and there are some colleagues who try rejuvenating the ovaries or with ovarian tissue and so on. It does not work. We don't have anything reliable. That's my opinion.
Okay, so I'm sure there could be some difference of opinion here. Dr.
Sure.
Evangelos, and then I'd like to go to Dr. Elena, because I know you mentioned some supplements earlier. I heard it in one of your answers. So Dr. Evangelos, we'll start with you, and then we'll move to Dr. Elena.
Okay, as Nicole mentioned, sorry.
Oh, sorry. I'm going to come to you at the end, Dr. Elena, if that's okay, and then you're going to. So Dr. Evangelos.
I totally agree with Nicole. I think it was 2 or 3 years ago at the ESHRE Congress at Milan in Italy, where they took in consideration all the RCTs. RCTs means on the randomized controlled trials, so the most strong trials, the most reliable trials, based on what can be done to improve egg quality. So as Nicole told us, GH, rejuvenation, antioxidants, all the stuff you can imagine, DHEA, no one of them showed a superiority as far as the result of the egg quality is concerned. No one. So maybe there's some stuff going on about the ovarian quantity, and maybe the rejuvenation could help us a little bit, or maybe the DHEA, but the ovarian quality, I totally agree with Nicole, there's no improvement that can be done.
Okay, thank you. That's really clear. And Dr. Elena, please tell us what you think and what your practice is. And I want you to add an extra dimension, please, because obviously there could be some benefits that, we talked earlier in the question about you're looking for one thing and then you get some other information. There may be some sort of, general benefits of using supplements that aren't specifically improving egg quality. But anyway, fire away, and then I've got a very specific question for you at the end.
Okay, as both my colleagues have mentioned, there's no proven drug that can improve egg quality. No randomized control trial can prove that we can improve the egg quality. Maybe we can improve with different strategies, maybe to get 1, 2 eggs extra. But even when we have done PRP, stem cell therapy, all kind of in vitro activation of follicles, all that stuff that trying to rejuvenate the ovary, which I think is a totally wrong term that we are using, because we are not making the ovary younger. If you are 42, around 85% of your eggs are going to be genetically abnormal. So you are not making it younger. You are not improving quality. You cannot do that. Maybe you can add one extra egg, but will be exactly in the same percentage genetically abnormal. So we cannot improve egg quality. Maybe some strategies could try to get maybe 1 or 2 extra, but we are applying these things. We are making the idea in our patients that this is going to be the flu and this is going to be the one that is going to work, and they are spending a lot of money and time and psychological burden as well, and we have to be very honest. The most important predictor factor is your age and then your ovarian reserve. You must be very clear what you can offer. If you are 40 years of age, around 60% of your eggs are abnormal. Your pregnancy rate maximum could get 20%. Only if you can get the nuclear embryo, then you will have a good probability to have a live birth rate. I think it's very important that all those things are very clear to our patients. Then there are some strategies. For example, we receive in our center many patients with endometriosis. Endometriosis is chronic inflammatory disease, and we see in these patients not that we are improving the quality, but we are improving their lives, because we can use diet, we can use supplements, antioxidants that will feel them better, reduce the level of inflammation, and that's going to make things easier. When we do the stimulation, they are not going to have be in such a pain. They are going to follow the whole therapy in a much easier way. So you have to be very careful when you advise things and be very clear. There's nothing that will improve the quality of the eggs.
Okay, thank you. I just want to, have a little follow-on question. So I don't know if it was you mentioned it, but, I've heard antioxidants mentioned, and I think, it's generally accepted that antioxidants at some level, whether in your diet or as a supplement, could be beneficial to your general health and possibly for your reproductive health too. But do you want to say, because I have this with clients quite a lot, particularly men, do you want to say anything about overdoing the supplements, like taking too many of them and the potential negative effects of that?
That is an important question, because we are trying to give the antioxidants because, we are thinking that when you are getting older, you are having more oxidative stress and mitochondrial, the function of the cells is not doing good. There are lots of oxidation, free radicals of oxygen that can damage not the genetics, but at least the way the egg is working. Sometimes I explain to patients, when you are getting older, you are getting an egg that is genetically abnormal, but it's not so competent. It's like you compare a very old car and a brand new car. You are getting to the place, but with the old one, you are doing things more slowly. Your metabolism is not as good. Antioxidants can help to, in general, a way of life is very important. We have to work for the weight. Obesity is a very important factor. There is more cytokines, inflammatory factors that can compromise the egg quality. Smoking is been proven to have an important effect, even diminishing and advancing the age of menopause. But antioxidants are good. Watching our diet, having a Mediterranean diet, avoiding all those high levels of sugar or carbohydrates and fats, fast food, things like that will improve your general inflammation state and can improve the competence, never the genetic. But you cannot think that we are eating, because I remember like 2 months ago, there was a lady coming and the whole table was covered with, and she was having vitamins for everything, for her thinking, for her sleeping, for her quality. This is totally wrong. Okay, you just, the most important is have a good diet, a good style of life, avoid the smoking, watch your weight, and have a healthy diet. That's the key thing.
Thank you. And yeah, I mean, just to sort of interject, I went to a really interesting talk at one of the side shows at the European meeting this year. It was about men, but I don't think it matters because I think it's relevant to women as well. But without going into a chemistry lesson for anybody here, you know, the opposite of oxidation is reduction. Okay?
Yeah, as bad as oxidation.
If you push too hard in one direction, you get something else. So my simple version of that is, if you take something to get rid of one problem, you create a new problem potentially. So that's why it's about balance. So if it says don't exceed the dose of even a supplement that's not going to kill you, but it might cause a different problem than what you started with, and you don't want that. Okay, perfect. So Dr. Nicole, we have another sort of specific, you know, patient-related question, but they're very nice and generalizable because they relate to a lot of people. Very similar to the first question. So this is a 38-year-old lady now. So she had 2 years ago, March 22, 2.3 picomoles per liter. Actually, that's quite low. And June 24.5, and advised to move straight to donor eggs. What's your thoughts on that?
Well, when I read the question further, she says that she already, because this is important, she already had 2 failed rounds of high stimulation, 3 eggs collected each time, minimal response to medication, 1 blastocyst, failed embryo transfer. So now when we know the history behind, we know the story behind how much time, money, effort, and emotions she has invested until now. So given her age and AMH right now, I think I would probably advise the same thing, and that is the donor program, because obviously we wouldn't be able, using any stimulation that we can imagine, we wouldn't be able to get as many oocytes as would be needed for her age to get a genetically euploid blastocyst. That means genetically healthy embryo. So yes, I agree. After all she has done already, I would as well advise for a donor egg. But of course we have very few information. Yes, I didn't see the uterus. I didn't see how the ovaries. So we must be careful with that. But given the information that I have now, I agree. I would advise for the donor program.
Perfect. And the reason I only gave you a bit of information was for that exact reason, so that you could say there is more information and I need to know it, because it's about context. And yes, you said earlier, which I thought was fantastic, don't get fixated on the numbers. The numbers are important and they do tell us something, but without the rest of the context, they're not meaningless, but they have less meaning. Great. Thank you very much. Dr. Evangelos. So this is my AMH earlier this year in January was 2.1 picomoles. Lady's 44, been doing IVF for the last 5 years, low ovarian reserve and male factor, so using ICSI. Get 1 to 2 blasts from 3 to 4 eggs, 10 egg collections and 6 transfers, but decided to go to Greece. So that's all in London. Yeah. 1 fresh round, 2 eggs, transferred at day 3, embryo of 10 cells. Sorry, I'm trying to sort of summarize. Okay. Very aware that donor egg is the most likely successful route, but believe that we can do this for our own eggs. So what do you think? And, you know, it's talking about in Greece, which I know is not necessary in every clinic, but using PIXI, Zymot for sperm selection, DNA fragmentation testing. Do you suggest anything else, or do you agree that this is worth doing, or, you know, what's your thoughts?
So if I understood well, it's 44 years old. That's right.
Correct.
Yeah. I'm surely convinced that she shouldn't continue with the same way. The egg donation should be the logical decision to take. If the patient wishes still to continue with her own eggs, of course, we cannot say no. But in that case, I would add the PGTA in order that the patient, at that case, should be convinced that the embryos, are really aneuploid, that are abnormal. So in that case, the decision to go to oocyte donation, maybe it would be more easy. All the other stuff that are being offered, like Zymot, Pixie, etc., I'm not convinced that's going to really help the situation. It's not a patient that had only one IVF stimulation. If I got it right, she had many IVF stimulation. They tried to go from blastocyst to day 3, from day 3 to day 5, so that really didn't help. Oocyte donation is the best way to resolve this problem until she wants with her own eggs, PGTA, just to have it, the proof. Okay.
And before I go to the other doctors, if they have a different opinion, I would say this is a definite case of ask that clinic that's offering all these different things, say, have you had a success with somebody my age? Whatever you do.
You know, Alan, can interrupt you. Even if because unfortunately many clinics were going to say, yes, I had many patients of 44 years old.
Show me the data, I would say. Yeah.
The data. Even if it's that, after all that medical history, it's really not logical continuing the same way. That's all.
No, I agree. I agree with you. And again, you're mentioning context, which I think is really important. Me just saying, have you had a success? If they say yes, then the patient would think, well, I can be one of those people too. If they say no, the patient can think, I can be the one that does succeed. So I get it. But I like to, it's a kind of a bit of a shutdown type of question, because if they go no and they show you the data, it's like, okay, that's you are talking about a very, very low success rate in that situation.
Alan, I was working for years in Brussels. That was where I got my education, my specialization at the UZ Brussels, and they had something like 5,000-6,000 cycles per year. After 44 years old, from 44 till 50, of course, they had no pregnancy with their own eggs. No pregnancy. It wasn't a center with 1-2 cycles per year. They had a huge experience. There was no pregnancy at 44. So, yeah, that's all.
Yeah, no, I appreciate it. And the reason I bring it up, I love, we're all talking about context, which is really important, but I've been on some of these Ask Your Doctor things before. And while I in my heart, I get it when a doctor says, but we do take into consideration the need of the patient, wanting to do it really. And that's absolutely paramount. At the end of the day, it's the patient's decision, with the information they're given. But there was a really interesting paper, white paper published by the American Society more than a decade ago. It was called Futile Treatment. And it was this concept of when the success rate gets lower than the risk of doing the procedure, then maybe you ought to be saying no, because the harm is exceeding the benefit. And again, we shouldn't fixate on the number, because I think it was 4%. We shouldn't fixate on the number, but it's definitely one where you think, okay, well, this patient is in this category now, and it's not just about what they want to do. It's about, I meet patients all the time who say, I've got a limited budget, but I want to try with my own eggs. And I'm thinking that's probably not the most cost-effective way of having a child then, to put it in those very blunt terms. Okay, beautiful. Thank you very much. Okay, Dr. Elena, how does long-term use of birth control affect AMH levels, or does it?
Well, the birth control pill, if you are, the things that could affect the AMH level, besides what you have mentioned, there could be, obviously variations in between our biology. It's been described that it's a very long uptake of the contraceptive that can diminish the AMH, and especially will diminish the size of the small follicles, which is also another way of evaluating the ovarian reserve. It can affect by the conditions on the lab. It can be affected by the intake of the pill. Smoking can affect as well, and it's not something that is fixed. It's variating. Also, it's been said and written in all papers that it's not intracycle variation, but intercycle variation. We can see that as well.
Thank you. I love to be able to generalize these questions and some of the answers. I think the generalization of that is when you're giving your history, to a doctor at a clinic, it's really good to give as much sort of relevant information as possible, because that little missing piece of information could make quite a big difference. You know, we've talked about the units of measurement. We've already talked about that. The context, how many cycles have I had before? Not just focusing on the AMH level. And I heard a really good story from a IVF doctor friend of mine in the UK, who does very, very thorough histories. And, you know, the lady eventually said, oh, I work in a nail salon. So she'd been exposed to some of the chemicals in a nail salon for like 10 years, you know, and so that's not something that's on your list exactly, but by getting a complete history and the patient sharing a lot of what could be very relevant information, it changes the picture quite dramatically. Great. So Dr. Nicole, my AFC is usually between 7 and 9. Can using a medication like Clomid or letrozole help me recruit more than 7 to 9 follicles?
That is a hard question. I would have to be a witch to know the future and the answer. Okay, but now I will try to think of a good answer now. Antral follicle count between 7 and 9 is very nice. That shows us a nice ovarian reserve. On the other hand, Clomid and letrozole, those are anti-estrogens. This is not an FSH stimulation. Anti-estrogen is something that, let's not get it too complicated, can help you have more follicles, have a polyovulation in this one cycle. But still, I do not think that Clomid or letrozole in a standard dosing would lead to more than 7 or 9 follicles. But it is really just an opinion. There are many variables that come into play. But just based on my experience, I do not think that only Clomid or letrozole would give us more than 9 follicles.
Okay, so this is a good one. You know, like you said, this is one of those ones where it's opinion, but based on your experience. Do any of the other doctors have a different experience or opinion on that one? If it's no, that's fine. Just shake your head.
No, I mean, if you really want to have the 7 to 9 eggs, I would use gonadotropins, or at least a combination of Clomid, letrozole, and gonadotropins. I totally agree with Dr. Nicole. You are not getting that good levels of eggs if you are using the Clomid on the conventional unit. Only if you have a huge ovarian reserve. Sometimes we use, for example, letrozole for inseminations, because I mean, this the problem we have for the gonadotropins is there is the risk for hyperstimulation, but only in very certain cases. If we really want to get these 9 eggs, I would use gonadotropins.
Totally agree.
Okay.
Actually, the average we have with the letrozole or with the anti-estrogens is 2, 3, maximum 4 sites. I've never seen much more than that. So if she wants to get all 9 of them, yeah, it's not that the solution.
It would be interesting to know the reason why she is asking this question. I mean, if I want 9 follicles, maybe 9 oocytes, I would probably stimulate. So, yeah.
Maybe she's afraid of stimulation.
Okay, perfect. Thank you. Oh, sorry. So I clicked on the wrong thing there. Okay, this one is directed towards Dr. Sakkas, so you're going to answer that one first then. Considering the rapid advances in artificial intelligence and machine learning, do you envisage a future where personalized fertility treatment plans are informed by algorithms that analyze genetic data, lifestyle, treatment outcomes, all the data we could possibly collect, in other words? And how might, that's a big question, how might AI enhance the precision and effectiveness of fertility treatments? Let's keep it in the realm of, you know, the stimulation, shall we? You know, focusing on how we can use the data. And there was a company, I don't know if it still exists, I can't remember what it was called, that was exactly what they were trying to do, but it seems to have disappeared. So what do you think about that fertility treatment plan based on using AI? Have you frozen, Dr. Evangelos?
Where we're trying to collect all the data in order not only to give the IVF stimulation idea, protocol, whatever you want, but also to give an answer to the patient, to the couple. So it should be a project that in the end, it would tell us, okay, you have given all that data, you have 50% to go with your own eggs, 70% for without donation, etc., etc. So yeah, this is something that is being studied every day. I repeat, we're doing that in order to give an answer to the patients, which is the best strategy to follow. Of course, in the future, we're going to use AI for the IVF stimulation. And of course, it's being already used for the selection of the blastocyst. Okay, so we're putting data now in order to see which blastocyst is the best one to transfer based on data from I think you as an embryologist, you know that better than me, which is the best blastocyst based on the time-lapse times and sequences and the velocity that we take from the technology. So yeah, AI is going to be absolutely used in the IVF stimulation and in all other fields.
Okay. Any other doctors, do you want to comment on what you think or how you're using AI in your clinic, if at all? Nicole?
I would maybe actually I think we all are already using the easiest AI, and that is the predictor for dosage of folitropin delta in PCO patients, because basically this is an AI system that helps us with the dosage of the gonadotropin in a PCO, especially in a PCO patient, based on her AMH and weight. Yeah, because weight is an important factor when it comes to the dosage. So this is a very easy and very helpful AI that we use in the daily practice.
We have already, I mean, all of us have started to use it in the lab, but I'm convinced, as Dr. Sakkas has told us, that we are going to use it more and more in our protocols of stimulation for our patients. I think it's a very nice hope. I think as we thought at the beginning of the time lapse, I remember our biologists were mad and spending hours looking at the embryos, and it does really help. And it will be the same for us as doctors in the stimulation field.
Yeah, I mean, you know, not to kind of build a wall between embryologists and doctors, but it took quite a lot of effort for embryologists to kind of accept that certain elements of their work could be done maybe more efficiently and effectively than a subjective human. And I'm interested to see what the timeline will be. You've mentioned one example already for dosing, but it seems like it's something that with a human oversight, it seems like something that would be a very good idea, given the numbers of cycles that are done every year, because we're talking about millions of cycles globally. So that's a big number. I suppose the only thing I would say is, just like any system, that comment about if you put rubbish in, you get rubbish out, right? So if you don't put the right information in, you don't get the right information out. And as with all, I used to work for the UK regulator, the fertility regulator, the HFEA. And, you know, one of the reasons why it's quite hard to always good information out is because you don't always have all the right information going in at the beginning. So you got a bit of a muddy picture at the end. And clearly, if you input incorrect or incomplete information, you can't really trust the result you get. But great question. I mean, my hope is that, you know, 10 years on from a company, maybe more than 10 years on from a company with the express purpose of doing this, we still aren't really doing it at the level they were hoping for. Okay. So, Dr. Elena, can digestive conditions such as IBS, Crohn's, etc., have a negative impact on ovarian reserve, or perhaps more importantly, egg quality? You mentioned Mediterranean diet already. Is a month prior to IVF cycle good enough, or is it too late?
I mean, first of all, both conditions are inflammatory diseases in your bowel. The best thing is to be under control, because one of our main concerns is when you have some comorbidities before you start your stimulation cycle, you need to be under the good control. So if you have colitis, if you have problems such as those, we must make sure that your illness is under good control. normally after when they enter the IVF system, of course, they have been having diet, they have been using drugs for the inflammation process, and we start stimulation when the illness is under control. And of course, I don't think it's gonna affect the anti-Müllerian hormone or the ovarian reserve. But we have understood that if you have inflammation in the digestive system, you will have also more inflammation in the pelvic area, and this is going to affect as well. Inflammation in the pelvic area will mean higher levels of cytokine, pro-inflammatory cytokines that can affect the embryo implantation. For patients like this with inflammatory problems, diet is very important. Make sure that they are free of disease before they start with the process. That can be for the Crohn or colitis ulcerosa. It can be also for endometriosis. We must make sure that they are stable, that we can reduce the level of inflammation, either with diet, with the style of life, and then AMH will be the same, but the condition for the uterus will be better, and the way they will follow the whole therapy, the whole process of stimulation is going to be better, because we must always remember that the quality of life is very important. If she is having a very inflammatory process at the moment, you shouldn't do any IVF therapy. First is her illness, and then we go into the IVF. But I think all those, the diet is of course is very important. Style of life is very important. Avoid all that sort of bad stuff, like as I mentioned, fast food or all these benzoids, colorants, all these ads on food you buy in the supermarket that is already cooked. Okay, we ask them to cook at their houses, to have lots of vegetables, fruit, blue peas, things like that. Red fruits, all those are antioxidants. All those will reduce inflammation. Sometimes we are really amazed, people having pain for endometriosis, and we just put them on a diet, on supplements, antioxidants, and they really come here and say, well, I am much better now. So it is important. The style of life is important, and we must make sure that we are doing the best job, because we can never forget she's a patient having an illness that we have to treat. That is first, and then we try to do our best job when we do the IVF therapy. But I think all this diet and style of life, as I've mentioned previously, is really important. Okay, but I don't think one month is enough. Okay.
Okay, perfect.
No.
So not just duration, 1 month. You know, because I don't think they were suggesting I'll do it for 1 month and that'll be the end. But we know with the spermatogenic cycle, so production of sperm, that really you've got to do stuff 3 months before and continue, because that's how long it takes to mature a sperm. Mm-hmm. But what would you say I mean, obviously people want to start straight away, don't they? They want to start doing the intervention as soon as possible, and they possibly want to do their IVF cycle as soon as possible for obvious reasons. So, I mean, what would be the minimum you would say? Or
we cannot postpone a lady who's 42, 43 for very long. Age again is very important. I mean, Mrs. Jans has got a good ovarian reserve. Then we will never we can try to get her on the best condition, but it will never postpone more than 2-3 months on a lady which is older, because then the cost effectiveness we've lost completely.
Okay, perfect. Thank you. I'm going to ask all of you about this, because it's going to be not so much to explain it, because I'm going to ask Dr. Nicole to explain what it is, and then each of you talk about what you think about it and whether you use it in your practice and for whom. So this is duostim or even tristim. So if you wouldn't mind just explaining what that is in simple terms, and then what do you think about it? Who, if you use it, and who you would use it for, please. We'll start with you, Dr. Nicole.
Okay, so the duostim is a short word for dual stimulation. Basically, what it is are 2 consequent stimulations, where the first stimulation starts as usual. Patient stimulates, let's say 9-10 days, then she has her oocyte pickup, And after the oocyte pickup, let's say 4 days later, she starts with a new stimulation. So there is no fresh transfer. The embryos from the first cycle have to be frozen, vitrified. So she's 4 days after her first pickup, she starts stimulating again. And then she can repeat it 3 times. That would be the tristim. The reason why we came up with the dual stimulation was, especially for women either who do not have the time, for example, fertility preservation in oncological patients with low ovarian reserve, so they can get more embryos in a shorter time, or patients who just want more embryos for a shorter period of time. To be honest, we are using it very rarely. I know there are a lot of data that you can find talking about the dual stimulation. Some of the studies are very very positive when it comes to the dual stimulation. Some of the studies are not so in favor. Our experience is that in these patients, usually patients with a low ovarian reserve, not even dual stimulation will give us any closer to a healthy pregnancy. There was another reason for the dual stimulation, and that was a possible different quality of the blastocysts, because some of the data showed that the embryos that we get from the second stimulation are of better quality than the embryos from the first stimulation. Not all data confirmed it, so I can't say this is true because there is still a lot of uncertainty, but that was one of the ideas behind it. So this is definition, and no, we are not using it regularly because from our experience, it is a financial load for the patient that does not bring us any closer.
Okay, fantastic. Really comprehensive. Dr. Evangelos.
Of course, I agree with Nicole. First of all, in order to begin with the dual stim, you must ask the health system, the national health system, if it can afford it, okay? Or if we are talking about private medicine, you have to see if the patient can afford the dual stim, because if we talk about Greece, it means that she has to buy the medication twice, she has to do twice the pickup, twice cryoconservation. So for a Greek patient, it's really a huge burden. So it is not a bad idea, but I confirm what Nicole said. Yes, it's a great idea for the fertility preservation, but that's all for me. Then I know that the studies that promote the dual stim talk about collecting more eggs. I have a philosophy about that. I mean, I believe that every cycle has its own quality. Okay, we have a quality in March, a quality in April, a quality in May. Every cycle of a woman has not great differences, but has a different quality in terms of eggs. Okay, so the dual stim, for me, going and just trying to squeeze the ovaries in one simple cycle, it's not something that really gives me more results. Of course, I tried it in the past. I didn't have more clinically pregnancies. I would say it was more or less the same. And as far as the study that Nicole mentioned about the second half having better blastocysts, it's really controversial. There are even studies telling exactly the opposite, that the second half has worse blastocysts. So I know that it's the great fashion in Italy, for example. They do it very much because I think it began in Italy. But I don't know many other countries that they do it so much. So for me, it's something nice for the fertility preservation, not much for the low MH. So we don't really do it. If I may, the only thing we do sometimes is for the patients that do the natural cycles. I mean, the patients that do not take medication, do not take IVF stimulation, and they just collect their eggs naturally by just monitoring their cycle. So these patients, yes, we do it. I mean that we do the oocyte pickup on the 12th, 14th day of the cycle, and what we usually tell them is to come once again after 7 days to see if there is another oocyte coming naturally not giving IVF. Until there is a second one, we just pick that one as well, but not by giving IVF stimulation, only naturally.
Okay, perfect. Thank you. And Dr. Elena, what's your experience?
Well, we use dual steam, but this is something that we discuss with the patient very, very thoroughly. If we have a patient with a low ovarian reserve, first of all, we need to explain what are her probabilities to become pregnant, depending on the age and the amount of eggs we can get. And then we explain on beforehand that there could be this possibility. And then once we have done the pickup and we have done the clone culture to blastocysts, if she just gets one blastocyst, if the quality of the blastocyst is not very good, we discuss again whether we try a second round of stimulation. We do have good blastocysts of this second stimulation. It's been published that the employee rate in between the first and the second stimulation is pretty much the same. Of course, there's no randomized control trial, but we discuss with the patient, because our problem sometimes is that if we ask her to do it immediately, she will say, okay, I want to try. I want to at least give myself the best opportunity to have a healthy embryo. If she fails for the first time, most probable, if she's 40 and she's not got any blastocysts, she's not going to try again. The dropout rate is really very high, and this has been established by many authors, especially in Italy, as Dr. Sakkas has mentioned. So this is something that we don't plan and do a thing. What we do is that we explain the probability, and then once we know what has happened on the first one, then we decide whether to go with the second stimulation or not. And it's, of course, it's always the patient choice. But our experience in this low ovarian reserve is that we get a higher number of eggs and higher number of blastocysts in the same menstrual cycle in a certain time. And time for these patients as well is very important. As I mentioned, when you are in your 40s, when they come here for the first time, they want to do things very, very quickly. But of course, we have to sit down and depending what is the result of the first one, decide whether we go on the second one or not. But we do this thing, yeah.
Okay, thank you. I think this has kind of already been answered, but so just raise a hand if you have experience with it, direct experience with it, not what you've read. PRP for ovarian rejuvenation. I don't think it's, I don't think you're going to be giving protocols if you're not doing it. So that's probably a no, isn't it? We already talked about that being not really proven. Okay, so final question, because we've got through everything, I think. And if we haven't, it's because some of the questions were very relevant to ones that had already been answered. So let's finish off in the order we started with. So Dr. Nicole, can you say anything about thyroid health on ovarian reserve? And we've already talked about reserve not being that influenced by other things, but let's expand it to quality as well, please.
Okay, so thyroid health is very important, not so much for getting pregnant, but for keeping the pregnancy. That is one thing that we have to clarify. If there is a thyropathia, if the thyroid gland is not healthy in any way, the main problem for this patient will not be getting pregnant, but keeping the pregnancy, not having a miscarriage. So unfortunately, there are no real supplements that would help the thyroid gland. If the thyroid gland is ill, that means you have either hypofunction or hyperfunction of the thyroid gland, you need to go on medication. And that is the only thing that can help you stabilize your thyroid health. When it comes to oocyte quality and quantity, I don't think there is any impact on oocyte quantity. I haven't read any study, any data that would confirm that thyroid health has anything to do with quantity. Quality is a different question because there might be a risk that is if a patient has an autoimmune disorder, autoimmune sickness of the thyroid gland, then these antibodies that the patient produces against her thyroid cells, she can produce a different antibodies that are harming her oocytes, her reproductive cells. So maybe the quality of oocytes in these patients could be impaired.
Okay, thank you very much. Dr. Elena, what's your opinion about dual or double trigger for oocyte quality? Is there an impact?
Okay, I don't think there is a real impact on the quality. I mean, the thing is that, it's been published. I mean, there are some authors that agree, others no, to have a double triggering with generate agonists and HEG is helping you to have more mature eggs. When we are using the analog, we have LH and FSH surge. I mean, is very similar what happens by physiologically. So there are many authors that believe that this is going to help the steroidogenesis and the final maturation of the egg, and then we are going to get more mature eggs. This is like comes and goes. There is even a meta-analysis being published on ladies with a very low ovarian reserve, and they have seen it's 1,000 people. It's quite an important one. They were doing the double stimulation, and in another 1,900 they were doing just the conventional one, HEG, and on their study they were getting more eggs, better fertilization, and better pregnancy rate. I believe for the low ovarian reserve, we are trying to do everything. We are trying to do our best, and I think this dual triggering could be something we can do, but it doesn't mean that it's going to make better quality, or not always we are going to get more eggs. Depends very much on the patient, but I don't think it's going to do anything on the egg quality.
Okay, perfect. Thank you. Right, we got one more question. I'm going to ask Dr. Evangelos, and then I'm going to ask him to give any final thoughts, and I'll go around each of you to ask final thoughts. So I may not be understanding this question correctly, but I think I'm going to interpret it in a certain way. I'm going to use the male as an example first. You know, people often talk about impacts on sperm quality, like temperature and occupation and things like that. So this person has put, given environmental factors, how can we mitigate the negative impact of ecology on ovarian health? But I'm going to take that as, you know, what environmental factors should patients be careful about to optimize their ovarian health? So we're not talking about diet or supplements. We're talking about, you know, environmental conditions, if any.
So actually two things I would say. The first of all is but something that you cannot really change. So the environmental pollution, unfortunately. Of course, that's something that together with the climate change, of course, it can change our quality of life and maybe the ovarian quality. I'm not so sure. There are many studies on that, but I can presume that there is a correlation between that. And then I don't remember the exact name. I think it's called not endorphins. There's some substances that they are produced by chemical things, and they go in the ground, and then we just, it's, you know, a circle that we just eat them by consuming normal things we buy in the supermarket, we go in a grocery store. So yeah, of course, a healthier way of living, a healthier way of eating, of course, it can improve our ovarian quality. But I don't think there are, I repeat, extremely many studies on that, and that there's going to be a huge improvement by doing something like that. Of course, if we talk about the partner, the male, yeah, that changes. You know very well that if somebody works in a toxic environment, I mean, getting in touch with toxic products, yeah, he can harm his sperm. But I don't think that's so important on the ovarian quality.
Okay, and I mean, the thing about sperm as well, it's a good model to talk about, is that the spermatogenic cycle is 90 days, so you have an opportunity to change things, and of course you can measure it easier. You know, you can produce a sample and see whether you had an effect. No, that's great. So whatever it is leaching into the ground, I guess not that we're saying to everyone buy organic food, but it's not just the type of food itself. It's maybe the way it's produced is making a difference, right? Just like
I really missed the word. I don't know how it's called. It's endocrinological
endocrine disruptors are
brava.
Yeah.
Thank you, Elena. Endocrine disruptors. Yeah.
That they are all over our place. It's not only in the industry of the food, it's all in plastics. I mean, we have it all over the way. If we are using our microwave and using a plastic thing to cook our meal, then we are
Elena, that's why I told in the beginning that I don't know if we can really change that, because it should mean that you're going to have to change the world. But
for example, in the clinic, we just use crystal bottles and all those. I mean, it's very bits and pieces, okay? But as soon as you know, and when you are cooking, your frying pans that they don't allow your food to get stuck in the pan, all those things have got these endocrine disruptors. We are surrounded by them, and I think, okay, well, and avoid it. You are going to the street, and there's lots of cars and pollution and so on. But as long as you can do it in your own microenvironment where it's under your control, why not? But it's very difficult, because whatever we eat is fish, meat, everything. It's got those biochemicals, and it's difficult to control. But at least it's education. And I think, well, if we have the knowledge, we can avoid certain things. That's all. Well, I mean, it's also financial question. Not everybody can afford having ecological food and things like that. We have to think about the cost as well. It's not so easy.
Yeah, thank you. I mean, one of the things I often say to people is, aside from any potential medical benefit that's specific to fertility, most of the things that we're talking about that are non-medical, they're good for general health anyway, aren't there? There's nothing you've said so far that would be like, oh, well, you know, it's going to make you feel a bit worse, but it'll improve your fertility. It's part of that holistic way of looking at things. That's great. So let's go around. Dr. Evangelos, any final thing, if you were, you know, summarizing in a couple of sentences about ovarian reserve, what would you say? And the other two can think about it, because I'm going to ask you to. Take home messages.
Actually, yeah, I would. The take-home message I would like to say is that okay, we should try as doctors, as embryologists, as society, to be honest, to try to inform better women, of course, their partners as well, but women about the concept, about the idea of the ovarian reserve. Fortunately, it has become a matter, has become an issue about which we are talking more and more, and it should be even more and more, because it's really a pity finding a woman at 32 years old with an AMH really low, and nobody told her before, or nobody had an idea about that. Even, you know, gynecologists have a look at a patient at 25, 30 years old, and they do not really recognize the ovarian reserve. So yeah, it's a very important thing. It doesn't really matter if it's going to be measured with AMH, FSH. We should be aware of the ovarian reserve as an idea. Patients should do it. As a society, we should do it. And yeah, we should also promote social freezing in patients that they seem to have a quick reduction in this, you know, on the ovarian reserve. Thank you, Alan.
Thank you.
And thank you all the colleagues.
That was perfect. Thank you very much. Dr. Elena, what would you say as your take homes?
Well, I think it's very important what Dr. Sakkas has just mentioned. For us as doctors, we have to be very clear on the options of becoming pregnant of this low ovarian reserve. That is the main thing. If they have accurate information, they will have better options to get the right decision. When I read, as you mentioned, this lady having 10 cycles, maybe she will find a clinic that will say, okay, I'm going to try this or that. I don't think that is honest, because in the end, what happens is that that lady will end up with no children, because she will be so fed up with all the ways she has gone through that then in the end she will not go into the explanation that that's the real ways it's going to become a mother. So being honest, having very clear what are the results, what are your chances, and then of course the patient should decide. And of course, very important, prevention is very important. We are delaying childbearing, we are having low ovarian reserve in relation to age. We need to explain how important is vitrification. Social freezing should have more support. It's a pity we see here patients with endometriosis and nobody has even told them that they could vitrify their eggs before they will end up on an egg donation program being 36, 37 of age. So we have to consider all that. And it's very important that we inform the society and even our own colleagues, because they do an ultrasound, they can count follicles and just say, okay, do you want to become a mother? Then you should do something about it. It's information, is the basics.
Thank you. I mean, it's really interesting. You know, you're sort of in agreement and you're all adding extra dimensions. And I'm going to come to you, Dr. Nicole, in a second. I mean, just want to say a thing about egg freezing. It's got a bit of a, bad rap in some countries. And I think that's because the focus has perhaps been on the wrong patient demographic. I mean, I say wrong, I don't mean wrong. I just mean that the focus perhaps should have been on people who are running out of eggs, not running out of time, if you see what I mean. So their quality is still good, but they need to freeze eggs now. So final word to you, Dr. Nicole.
Okay, so I think everything was basically said by my previous colleagues. So I will finish up with a message for our patients, for you women and couples who either will be treated for infertility or are treated, or who are actually thinking about your reproductive health. AMH as a marker of ovarian reserve is a great marker. It is the best we can get right now. So get it tested, get it done. Even if you had to pay for it, it is just one hormone, get it tested. Educate yourself about fertility, educate your children, educate your future daughters about fertility. Fertility doesn't last forever. It is very quickly gone, and you can lose your fertility in a glance of a time. So please educate yourself and your children. And the last information that I would like to close the conversation with is that all we talked about, AMH, ovarian reserve, ICSI, ZyMod, all the techniques of assisted reproduction, this is all great, but the most important factor is your age. So please do not postpone the pregnancy. And if you have a prospective partner, trust your doctor, trust the advice that we give you, because we want you to get pregnant yesterday as well.
Fantastic. Oh, you've all been amazing, honestly. And you probably think I say that to everyone. I don't. You've been an amazing group of doctors. And thank you so much for all the questions. I thought we might not get too many questions today, but they've been fantastic questions. I think we've done a really good job of explaining what to do about ovarian reserve, and particularly when it's low. So we're going to close this off now. Thanks, everybody. Thank you so much to the audience. I know you've given up a lot of time to be here. I hope it's been useful for you. Don't forget to look for the next one. Tune in for that. If you have ideas about what you would like to be covered, we always want to hear about that too. So thank you also to my IVF Answers for putting this on. Thanks, everybody.
Thank you. Thanks very much.
Thank you, everybody. Thank you.